All right, good afternoon, everybody. Thanks so much for coming. I think we're going to get going. I'm Josh Sharfstein, the Associate Dean for Public Health Practice and Training. This is the second in our Centennial Scholar Series. It's going to be a really great event. Can everybody hear me okay back there? Is the microphone on? Let's see. I don't know. You can hear me? All right, we're good. I'm getting a thumbs up. Yep. Okay, good. Okay. So today we are going to be talking about aging and disability in America, the role of the federal government in long-term support and services. And it's going to be, we have a phenomenal group of speakers, and we're going to have an interactive session. I'm here introducing this because the chair of the Department of Health Policy and Management, Ellen McKenzie, is not here. She has provided tremendous leadership to this series, and should also mention that Frances Henkel's donation made this possible as well. We're going to start, and I will have a chance to introduce Congressman Waxman in a bit and the other incredible speakers who are here. But to start, I am going to introduce Dr. Jennifer Wolf. Dr. Jennifer Wolf has taken the lead in actually organizing today. She is also an associate professor of health policy and management here, jointly appointed in the Division of Geriatric Medicine at the School of Medicine. She is a core member of the Lipitz Center for Integrated Healthcare, the Center for Aging on Health, and the Center for Innovative Care and Aging. I should just say that she is the leading researcher on caregivers. She's done a tremendous amount of work with the Institute of Medicine. She is one of the rising stars of the Department of Health Policy and Management, and she's going to give an overview of this incredibly important public health issue. Jennifer.
Thanks. It's my great pleasure to be here today and to kick off our public forum. Just to make sure we're all talking this same language, let me start by defining long-term services and supports, which refers to institutional or home-based assistance to meet the needs of individuals who have difficulty with basic self-care activities such as mobility, bathing, or dressing, as well as household activities that are essential for community living, such as shopping for groceries or preparing meals for health and functioning reasons. One of the challenging issues in long-term services and supports policy is that the strategies that are used are highly diffuse and influenced by the availability and adequacy of social and economic resources, such as family structure and interpersonal dynamics, as well as attributes of the home and community environment in which individuals live. Strategies that are used to accommodate disabilities are highly varied and include paid or unpaid personal care assistance, community services and supports, including use of assistive devices and environmental modifications, as well as institutional care. Although long-term services and supports is financed separately from health services, individuals who have long-term services and supports needs also commonly have complex health needs, so service coordination is also critically important in the financing and delivery of care. There are approximately 12 million Americans with long-term services and supports needs, including about 6.5 million older adults, about 5.5 million working age adults, and just under 1 million children. The top shaded segment of each of these bars in blue indicates the numbers of individuals with long-term services and supports needs who receive care in an institution. The key points that I want to make are that individuals of all ages have long-term services and supports needs, that most individuals' needs are met in the community, and that older adults as a group are most likely to receive institutional care. It's anticipated that the numbers of Americans with long-term services and supports needs will roughly double over the coming 30 years, alongside proportionately fewer working age Americans who contribute payroll taxes that fund Social Security and healthcare entitlement programs, raising a key question of who will care for and pay for long-term services and supports in the future. I'd like to turn now to the costs and financing of long-term services and supports, and to ask each of you to consider the annual costs of care in a nursing facility today. Would you estimate those costs to be about $40,000, $60,000, or is it closer to $90,000? The bottom line is that long-term services and supports are expensive. Although costs vary widely by geographic region, type of facility, and the ability to pay full freight, average annual costs for a semi-private room in a nursing facility exceeds $80,000, and costs of care in a private room exceed $90,000, or about $250 a day. Average costs of care for in an assisted living facility or for a full-time personal care attendant or homemaker are on the order of $45,000 a year. These costs are not inconsequential, particularly when we consider that median annual income of older adults as a group is approximately $25,000, and median assets are approximately $65,000, or less than the costs of a single year of care in a nursing facility. It's estimated that about 15% of all individuals turning 65 today will incur more than $250,000 of lifetime long-term services and supports costs. So considering the high costs of long-term services and supports, who pays for this? Is it predominantly Medicare, Medicaid, private long-term care insurance, or is it predominantly out-of-pocket costs by individuals with disabilities and their families? These two pie charts display the expected lifetime sources of financing of long-term services and supports for the cohort of individuals who are turning 65 today, for community-based care on the left and nursing facility care on the right. The takeaway point is that private insurance, shown in orange, is expected to finance a trivial portion of long-term services and supports in both settings. Focusing on the left pie chart, we see that out-of-pocket payments dominates community-based long-term services and supports, while public financing, mostly the Medicaid program, dominates financing for nursing facility care. One of the recurring discussion points that was raised in the public forum that was hosted by former Congressman Waxman and Dr. Karen Davis is that on Medicare at 50 is that Medicare does not cover long-term services and supports. This gap in coverage poses significant challenges in the delivery of high quality and efficient care for some of the most vulnerable beneficiaries, and too often results in potentially avoidable injuries or hospitalizations due to unmet needs with daily activities, such as going without food because of an inability to shop for groceries. Because any discussion of long-term services and supports requires a basic understanding of the Medicaid program, I wanted to say a few words about the program here. Medicaid was established in 1965 as an open-ended entitlement program. Its origins emanated from the public welfare system. And to be eligible, individuals must have both low income as well as very low assets on the order of $2,000 to $3,000. The program was intended to assist individuals who are not expected to be in the labor market, and therefore imposes categorical requirements that include age and disability. The program is a federal-state partnership in which the federal government establishes overall guidelines and each state administers its own program. It's important to distinguish between statutory benefits that are mandated by federal guidelines and optional benefits that are offered at a state's discretion. With regard to long-term services and supports, statutory benefits include nursing facility care and skilled home health care, and as a result, there has been a traditional bias, structural bias towards institutional care, although the range of benefits and the mechanism for community-oriented benefits have increased in recent years, due in part to the Americans with Disabilities Act and Supreme Court rulings that mandate provision of care in more integrated settings. These data are from the Kaiser Commission on Medicaid and the Uninsured, which Dr. Diane Rowland has directed since 1991. These data show average Medicaid payments per enrollee and indicate that Medicaid beneficiaries with disabilities and those 65 years and older are approximately 5 to 7 times more costly to the program than adults and children. Focusing on the far right bar, we see that costs associated with long-term services and supports for older Medicaid beneficiaries in 2009 on average approached $10,000. As I mentioned before, Medicaid spending on long-term services and supports has been shifting towards community-based care. This slide, also from the Kaiser Commission on Medicaid and the Uninsured, indicates that in 1995, approximately 80% of every Medicaid dollar on long-term services and supports was directed to institutional care, but that by 2011, spending was nearly evenly divided between the community and institutional care. In his capacity as chair of the House Energy and Commerce Committee, former Congressman Waxman played a highly influential role in stimulating many changes to the Medicaid program, including the shift towards community-based care. We'll shortly be hearing from former Congressman Waxman and Dr. Diane Rowland, who worked with former Congressman Waxman in the 1980s at the time that these changes were first beginning. And we're fortunate to have Mark Leeds here, Director of Long-Term Services and Supports in the state of Maryland, to speak to the challenges and opportunities of rebalancing efforts here in the state of Maryland. Although private long-term care insurance has existed for many decades, uptake has been persistently low, and it is estimated now that approximately 10% of older adults have any form of private long-term care insurance. Because of the significant public financing of long-term services and supports, growing the market for private long-term care insurance is of great interest to state and federal policymakers. Doing so, however, is far from simple. In part due to demand-side challenges that relate to low consumer savings, limited knowledge, and competing priorities. On the supply side, challenges relate to immaturity and complexity of the long-term care insurance market, the fact that most policies are purchased on the individual market with high underwriting costs, and the very long time horizon for the use of these policies alongside low industry credibility and trust. We're very fortunate to be hearing from Dr. Judy Fader today, who's been highly involved in numerous policy initiatives to strengthen the role of the federal government in long-term services and supports, and who recently served as a member of the Commission on Long-Term Care. Drawing on recent estimates from the National Health and Aging Trend Study, the final point that I want to make is that the vast majority of long-term services and supports is provided by family and unpaid caregivers. The left set of blue shaded bars indicate that just 5% of older adults with disabilities exclusively receive paid help, and that 2/3 or 66% exclusively receive unpaid help from family caregivers, while about 30% receive both paid and unpaid help. The far right set of bars displays the mean number of monthly paid and unpaid hours of care received by older adults with disabilities, and indicates that unpaid hours of care is about 6 times higher than paid hours. Although these unpaid hours are not formally included in the accounting of long-term services and supports, they are not without significant emotional, physical, and financial consequences for individuals, for families, and for society. And with that, I'd like to turn the podium over to Judith Vick, who's a medical student here at Johns Hopkins and who's graciously agreed to share her story with us today. Thank you.
Thank you so much for having me speak here today. It's an incredible honor to be on this, the same program as this panel. One day I hope to be on such a program based on my scholarly contributions, but today I'm here to tell you about my family story. This is my mom when she was about my age. This is my mom about a year ago with my niece, my brother, her granddaughter. Between the first photo and the second, she married my dad, went to grad school, got her PhD in art history, taught at various universities, had 3 kids, worked as a museum curator, divorced my dad. About a year ago, she got engaged to be married to a really great guy named Bob. In November 2014, she was perfectly healthy, really boring past medical history. She had been vegetarian for 30 years. She had not consumed refined sugar for 30 years. She was until November 26th, 2014, when she was traveling in Jerusalem to visit them, and she had a massive hemorrhagic stroke. She was brought to the hospital right away and had an emergency craniotomy and craniectomy in which they removed half of her skull to give her swollen brain a place to go. When I got the phone call about the brain bleed, I was sitting on my couch in my Upper Fells Row home. I was studying for an exam on the GI system. And instead of taking that exam, which I still haven't taken yet, I flew to Israel. And my younger brother and his wife, who live in California, also flew there. My mom was in the surgical ICU at that point, and She then moved to the neurosurgical ICU and then to the medical ICU. And then finally, about 2.5 weeks after the bleed, they moved her to a regular medical unit. And the doctors told us that that point was as good a time as any to transport her back to the U.S. So we bought 16 seats on a regular commercial flight, and they put the stretcher on top. She was still comatose at the time. And we flew back to Newark, where a patient care ambulance from Hopkins came to pick us up. Insurance didn't, no one paid, I mean, we paid out of pocket for the international flight, and then insurance did pay for the domestic transport. At this point, it was abundantly clear that my mom's recovery was going to take a very long time, and though I probably could have caught up for the 3 weeks that I had missed from school at that point, I decided to take a year off from medical school to be with my mom during her recovery. From Hopkins, my mom went to acute rehab for about a month, and then subacute rehab. That's this photo is when she had the helmet, when she didn't have the skull, and then she came back to Hopkins for her cranioplasty, and then she went back to subacute rehab, and then she came back to Hopkins when she was dehydrated and had C. diff, and then she went back to subacute care, and then she went back, and then finally, in April 2015, she went home, though she's been in the hospital twice since then, last week, and actually right now we're, again, waiting for another transfer from a regular medical unit to a neuro unit. In case you lost count, that's, and I have, since there's been a change since yesterday, that's 10 places of care and 8, soon to be 9, transitions of care. I also moved back home when my mom went home in April. I moved from my Upper Fells Row home to my childhood bedroom, and Bob, my mom's fiance, also basically moved in. At that point, she could not transfer herself from the bed to chair to commode. She could not sit on the edge of the bed and balance herself. She couldn't roll over in bed by herself. She had no use of her left side, her left arm, or her left leg. She regularly neglected the left side of her body, so she'd hold her left arm in her right, and she'd ask me why there was a fake arm in her lap. She needed to be reminded to eat the food off the left side of her plate, or wipe debris off the left side of her face, or even wipe her nose if her left nostril was running. She couldn't be left alone. She still can't be left alone. What if she needs to use the bathroom? What if she does try to get out of bed or slips out and falls? And what happens in an emergency? And the truth is, it's more than the basics my mom needs. She needs a caregiver, she needs a companion, and she needs a coach. She's had amazing physical, occupational, and speech therapists, but what they've all said is that it's incredibly important for her to be working when she's outside of her therapy sessions. And in order to do that, she needs someone to do her exercises with her, for someone to encourage her to do all of these things as much as possible on her own, so she's using her own strength rather than just doing things for her. She also, very thankfully, has a lot of her cognition intact, and she needs someone to talk to her about art history and to talk about the news and to talk about politics. Basically, she needs a son or daughter to be with her who's not her actual son or daughter. I was, at first, the main hands-on caregiver for a while, waking up with her in the middle of the night and always being at home with her. But soon we hired an aide who could transfer my mom from bed to commode to chair, which was a huge relief, but she was unreliable. She'd come 30 minutes late, 45 minutes late, 2 hours late, a different excuse every time. And so for the first time in my life, I had to fire someone. And I had never done that before, and so I had gone from a medical student to a caregiver and really a manager, hiring and firing in a very short period of time. After our first aid, we hired someone new who was fine, provided fine care for my mom, but really at the beginning of the summer, we struck gold. I was talking to the visiting nurse who was visiting my mom at the time, and casually talking to her about the situation, and she said, well, my stepson Kevin is looking for summer work. And he's 20, he's a basketball player. He's between his sophomore and junior years of college, and he was absolutely amazing. And I could spend the whole time talking about how wonderful Kevin is. A friend of mine calls him a caregiving wizard. But the point is that it was really luck that we found someone like that. He's 20. He had no experience at all before that, and he was just home for the summer. So he went back to school at the end of August, and we're still trying to find a stable, long-term caregiving situation for my mom. Of course, in many ways, we've been incredibly fortunate. My mom's acute care in Israel was amazing and saved her life. The bleed was on the right side of her brain, and she's right-handed, so it affected the left side, and she has the use of her dominant hand. Her language is perfectly intact, and she remembers every single detail from her art history PhD. I had recently moved back to Baltimore after being away for 10 years for medical school, which has been very good for my family. And I've been able to take a year off from school and work with Jennifer Wolf on caregivers in the healthcare system, which is absolutely the perfect job at this point. And Jennifer is such an amazing and understanding boss. And of course, until this point, we've been able to pay for everything. My mom's Jewish community has been incredibly supportive and generous, including helping with costs. But the truth is that the funds are limited, and we, at this point, have no idea how long my mom will need paid caregiving. And most especially, we are both me and my mom, are incredibly fortunate to have Bob. He is the most wonderful, caring, and loving man, and he's worthy of my mom, and I have not said that about any other person for my mommy. On June 30th, 2015, 7 months after my mom had her stroke, oh, that's Kevin. I forgot to show this picture. That's Kevin and me and my mom getting pedicures. Anyhow, on June 30th, 2015, my brothers wheeled my mom halfway down the aisle, and she met with me and Kevin and walked the rest of the way down the aisle to meet Bob under the chuppah, and they were married. But as lucky as we are, and as fortunate as we are, and as joyous as the wedding was, there are still incredibly difficult issues. How am I supposed to find adequate care for my mom? How are we supposed to pay for it? How am I supposed to find really good care for my mom to give her all that she needs? I have this nagging inner voice that medical issues are issues, but the caregiving issues maybe aren't issues. I can provide care for my mom, and I'm certain that I can provide quality care for my mom. So she has access to me, she has access to quality care. After all, it's only recently in the history of caregiving that, or the history of healthcare, that we expect others and not family to take care of those who can't take care of themselves. But no professional has told me this. In fact, professionals have said the opposite, that it's better for us to return to normalcy as soon as possible, as much as possible, for her nearly 30-year-old daughter not to be living at home with her husband. And certainly, if I'm going to be a doctor, which is what I want to do more now than ever before, I can't be home all the time, or even much of the time. And that's to say nothing about my emotional well-being and my ability to be her loving daughter. I can't be her companion, caregiver, coach, doctor in training, and be her loving daughter. And really, it's that last role, that of a loving daughter, who I really want to be for my mom. Thank you so much for having me speak today. I'm inspired that there are so many people working on these issues, and I'm very appreciative.
Wow, thank you so much, Judith, for that tremendous presentation, and thank you also, Jennifer, for really setting up the issue. We're now going to bring up Congressman Waxman and Diane Rowland. Congressman Waxman, as many of you know, is a Centennial Policy Scholar here. He served in Congress for 40 years. He, at the last session we had, Sean Cavanaugh, who is the current director of Medicare, said that when he went to work on Capitol Hill in the mid-'80s, Congressman Waxman was a legend for all he had accomplished at that time. And then he proceeded to serve more than 2 decades beyond that with such tremendous accomplishments. Many of the legislative policy changes in Medicaid came through his committee under his guidance that we'll be talking about. In addition, he had the key role on legislation as varied as the Ryan White CARE Act for HIV, the Clean Air Act and Clean Water Act amendments, the Affordable Care Act, and many other pieces of legislation. I think for me personally, having worked for Congressman Waxman, it's great that he's here. This is the centennial year for the school, and he is really the centennial health policy legislator. So Congressman Waxman, why don't you please join us? And I'm going to also ask Diane Rowland to come up. Diane is a nationally recognized health policy expert. That would be understating it. She is the director of the Kaiser Commission on Medicaid and the Uninsured that Jennifer was citing. She works on multiple major national committees that establish the key policies on some of these major issues, including the Medicaid and CHIP Payment and Access Commission. She is an alumna of the school with a Doctor of Science in Health Policy and Management here. She was saying that this was originally called the East Wing Auditorium, so I learned something there. So Diane and Congressman Waxman, please join us. Thank you.
To interview Congressman Waxman. I've listened to him in many interviews, and I know that he is an incredible person to interview. And I kept thinking when I heard the story that we just heard from Jennifer and from the statistics on long-term care that Henry probably needs to serve another 40 years in Congress so we can actually get this done. But really, today, we're looking at the road to long-term care reform, which has been a long and rocky one. Efforts at comprehensive reform, adopting a social insurance approach, or pursuing private long-term care insurance have all fallen short. So over the last 50 years since the enactment, Medicaid has been the nation's frontline program for assisting those who struggle with the need for long-term services and supports to supplement family caregiving. And Medicaid's role has grown and been strengthened over the years, largely by much of the legislation that came through the Energy and Commerce Committee, and much of what was introduced by Henry Waxman, supported by Henry Waxman, and enacted because of the force of Henry Waxman. So we really owe him a real debt for the fact that there are some services available in the community today, and that Medicaid is being rebalanced from nursing homes to community-based services and supports, among all the other things that the Medicaid program and the low-income population of this country owe to the legislation over the 70s, 80s, and 90s, and into the current time with the Affordable Care Act. But today I'd like to tap your experience, Henry, and your keen legislative insight on how to move policy so that we actually can accomplish what needs to be done in long-term care. And let's reflect a little on the successes and setbacks of the past, but most importantly on the lessons from the past toward the future. So one of the first things I'd like you to really focus on is Medicaid's role has been so dramatically changed, especially through the 1980s and 1990s, with nursing home quality reforms, waivers for home and community-based services added, and today we see continued efforts to provide more community-based care. But how does that history inform current debates? What factors and forces really led to the changes? What was the role of oversight committees and others in trying to get these things through?
Well, when Medicare was adopted in 1965, it was to take care of the medical insurance needs of the elderly and disabled people, and it was a godsend to so many people. And the promise that was made was that when you're in your golden retirement years and don't have a job, and that usually meant since people had their insurance from their jobs, you would have insurance coverage for your health care needs at a time in life when you'll have a lot of health care needs. And I'm sure if we looked at the speeches given at that time, we'd see statements that no one need fear the cost of medical care any longer. But the truth of the matter, as we know now, we in this room know now, a lot of people in the country don't know, is that Medicare doesn't cover those horrible, very huge expenses of long-term care. We didn't have Medicare covered except for a short period of time after acute care services. If a patient needed short rehabilitation care after being in a hospital. So the Medicaid program, which was adopted into law at the same time, was looked at as the program to fill this gap, but that doesn't really make any sense because Medicaid was a program for very poor people. And to be on Medicaid, you had to be exceedingly poor, usually tied to a category, aged, blind, disabled, or aid for dependent children. But if you spent all your money for care and had very little left, then you could become eligible for Medicaid. If you became eligible for Medicaid, Medicaid would pay for medical services, and if you're on Medicare, you've got coverage from both programs. But Medicaid covered, whether you're on Medicare or not, the long-term care services. But it was, for the most part, exclusively in a nursing home setting. So you had to be very poor in a nursing home for long-term care services to be paid for by any public program. And that excludes, of course, most people. And the human story we heard a little bit ago illustrated how the family had to pick up all the costs. And that's repeated over and over again. When we started looking at this issue, there were a lot of pressures to say, let's do something to expand the amount of services that are available to people who are at least on Medicaid, and make sure that if you're on Medicaid, you don't have to go to a nursing home. If there are alternative services that would, in fact, save money, because nursing home costs are more expensive than community home care services. And so in the 1980s, the Congress adopted the home and community waiver provision in Medicaid. And states were permitted to provide alternatives to nursing home care. That was, of course, very, very important, but it was limited. Is it still limited?
It's now an optional service.
But it has to be no more than what the nursing home would cost.
Right.
So you have to come in and show, if you don't provide
waiver.
these services at home or within the community, some other alternative, then a nursing home, if you provide those services outside the nursing home, it can't cost more than if you're in a nursing home. Well, that generally fits in well enough because people would prefer to be out of a nursing home for as long as possible, and then these services were. But you still had to be very, very poor. Well, there was public pressure on this issue. We had Human Face, as we had a presentation earlier, about what happens to people if they don't have this kind of approach that would be available to them. Some of this states' options, some of the Medicaid changes that we've made over the years.
Here Henry's being quite modest because at the time he tried to make this a mandatory benefit under the Medicaid program, and there was so much resistance to something called the woodwork effect, that all these people would suddenly start using Medicaid services, that the waiver with these cost provisions was the best we could do at the time.
You always looked in the world of government and politics at how far you can go. What can you actually pass into law? So at least we got an alternative to nursing home, and at least we got the states to have a choice, and a lot of people were benefited. But you still have to say, well, what about all the people that are not on Medicaid, that are not reduced to poverty in order to be eligible for the program? And Medicare has not been there to pick up the slack, even though Medicare is supposed to be the primary program for medical care. But there's a distinction that's made between medical care, acute medical care, and long-term care services, and that's a distinction that we still have to make.
And I think that this is a great example, though, of the strategy of doing incrementalism versus doing comprehensive reform. And perhaps one of the best lessons from the Waxman era is if you take it with a vision of where you're going and you keep plugging through year by year, whether it's around pregnant women and children, or whether it's getting the expansion of these kind of services or protections for the spouse remaining in the community when someone is institutionalized. But what advice
Those
would...
are all issues that were dealt with incrementally, not with one fell swoop.
So one would ask, what advice would you give to the reformers of today about how to get the changes they want put into place? Does it take having someone in Congress for 40 years to keep plugging away? Or how would you motivate change today compared to what we saw in the 80s and 90s?
There are a number of tools that we need. One, statistics, the solid framework of understanding how widespread the problem is. And I'm so impressed by the work being done here at Johns Hopkins School of Public Health to give us that data. We need people who will come forward and talk about their own personal family experiences. And that is hard to find because while people deal with these problems, they may not be public about it. They may not want to be public about it. But let me give you an example, a concrete example of one of the Medicaid changes that we made. People were in nursing homes, but the reports of poor services in nursing homes kept on coming up over and over again. We held some hearings about it. We hear from people who would say, my mother and my father were in the nursing home, that when there was less money for the Medicaid program, they would lie in bed until noon because the nursing home didn't want to spend money on another nurse. They didn't want to spend for another salary. In other words, it saved them money not to provide good care. And we heard from people about what that was like. That maybe was a benign example. So you were warehoused in your bed for many, many hours. You can certainly imagine how awful that would be. But many seniors were drugged or restrained. And that helped the nursing home deal with its problem of having less support staff, and therefore the quality of care was reduced. So we heard about these problems. We had hearings about it. There were press stories about it at the local level when the case was revealed and at the national level. And finally, we asked officially the Institute of Medicine to do a study on nursing home quality care and to compare states, because Medicaid is run by each state. So they came back with a report a year or so later and said some states are doing a great job of monitoring and regulating and assuring good quality of care, but some states could care less about the problem. So the Institute of Medicine recommended that we have a federal standard for quality of care in all nursing homes. We are using federal taxpayers' dollars to pay for maybe 50%, maybe 80% of the costs of the nursing home under the Medicaid program. So we finally got to the point where we were able to adopt federal standards for nursing home legislation. Just as an aside, I want to tell an anecdote about that. In 1994, there was a revolution in Congress. The Newt Gingrich generation came to power, and they all had talking points. They all said the exact same thing over and over again. One of my colleagues who had been in Congress for a while said, you know, these are like the people that we couldn't stand that showed up at our community meetings. They all had the same thing over and over again. And on Medicaid, they said, why don't we take Medicaid and just turn it over to the states? In fact, they say that about most states. Because they're so much closer to the problem. We in Washington are in many ways, thousands of miles away from the problems, but the people at the local and state level are living with the community and know the problems and will do something about it. And I said to them, well, that's an interesting idea. I'm sure people at the local level would want to do something about it, but they might not be able to do anything about it. What would you say about nursing home quality standards? Should that be left to the states as well? Oh, of course. Of course, because they're close to the problem. They would never tolerate poor nursing home quality standards in a state where they lived. And then I had to say, well, as a matter of fact, the history was that they did a very poor job, and that's why we had federal standards. But it was an example of how we had to lay the groundwork to get the nursing home quality standards. And the same was true for the spousal impoverishment. We kept on hearing about a spouse is in a nursing home. More likely than not, the husband. The wife is at home. The wife generally could be a number of years younger. Maybe not even on Medicare. But even if she were, she's covered, that's good. But the nursing home costs are being paid for by Medicaid. And to get eligibility for Medicaid, I don't know if it's true in every state, but I know in the state of California, probably here as well, you had to have no more than $2,000. So you have to take all the money you've saved up in your working years and start paying for a nursing home. And then when you have nothing more than $2,000, then Medicaid will come in and help pay for it. Well, that's pretty humiliating to have your money spent. But as humiliating as it is, imagine the spouse. They have no more than $2,000, and then the husband or the spouse in the nursing home dies, and then what's the other partner to do? Just to pay for living expenses as a survivor. So we kept on hearing more and more stories about that, and finally we said, no, we're going to allow a certain amount of spousal support to be there, not to take it away to pay for nursing home costs. And we've tried to address these issues bit by bit as we could over the years, but each one of those bits ignored the huge problem on the one hand, but was so important to the people who were benefited on the other hand.
And I think, Judith, if you wonder why telling your story isn't important, you've just heard that it really isn't all facts and statistics. Much of what changes legislation is the human face, the stories, and the relationship of the people to the statistics, to the politicians, and the pressure on them to make a change from either the press or the public.
Could I just wait? I feel probably ready to get the rest of the panel on, but to give you an example of that, there was a young girl named Katie Beckett. Katie Beckett was disabled from the beginning. She was not able to function on her own. And so she was in a hospital. And while she was in the hospital, Medicaid would pay for her services. And Medicaid paid for her services, but They wanted her to come home. And but the reality was, if she came away from the hospital and went to live at home, certainly less expensive, the income that her parents had would be attributed to her, and she would no longer be eligible for Medicaid. So it was one of those terrible catch-22 situations. And her local congressman, Congressman Tom Tauke from Iowa, heard about this and said, that doesn't make sense. And so we had a specific bill that was introduced and adopted that changed the rule so that we don't force people to stay at an institution and deny them Medicaid if they have the ability to leave. Another example, which I had completely forgotten about, but I was reminded that it was called the Aunt Molly provision. My Aunt Molly. And the situation was that my uncle, Sam, her husband, was in a nursing home. And they paid for him in the nursing home. He had a stroke. He was quite disabled. His wife took care of him at home for maybe a decade or more. And then he had to go to a nursing home. She wasn't able to care for him. He went to a nursing home. She continued to pay for it, and she had no more money left. So he then became eligible for Medicaid. And the nursing home said, oh, now you're on Medicaid, and you're no longer paying for these services. We're going to transfer you to a nursing home that is just as good but not as expensive. Now, you know what that means. So she came to, I presume she came to me, but she probably went right to the staff, if she knew how things work, and said, that doesn't seem right. And we've had a provision in there, the Aunt Molly provision, that said you cannot transfer somebody from a nursing home when they become eligible for Medicaid. If they're in a nursing home, they can continue to stay in the same nursing home, they can continue to get the same services, whether they're on Medicaid or they have private pay for their services. So individual situations brought to members of Congress who are influential, like Tom Tauke and myself, were able to make changes. But we need people to bring it up over and over again to their representatives and to get representatives who are going to listen and take advantage of opportunities to advance the cause for those people, but for all the other individuals that will be benefited by changes. But the last thing I want to say is, you know, most people in this country, if you took a poll, don't know that their long-term care costs are not covered by Medicare. They think they're protected. And it's just an awful, rude awakening when it happens to them or members of their family to find out that they have to go through the indignity of becoming impoverished to get any help. And they are Americans and they worked hard, and right now so many of them were the great generation that lived through the Depression and fought World War II. And we still haven't solved this problem. We can do some things incrementally. There are things we could try to do, but it's when we passed a bill one time called the Catastrophic Protection for the Elderly. And that sounded like the solution. But it was a bill that would have taken the expenses that were not covered for acute care services under Medicare and made the elderly pay more money to their premiums to have that insurance coverage. But it did so little on the long-term care issue. And when seniors heard about it, they said, you're not protecting us from catastrophic situations. That's nursing home care. That's long-term care. It's alternatives to nursing homes. And this catastrophic bill had such a negative reaction because seniors were paying for it, many of whom thought that they had private insurance to pay for it. We actually repealed the law. But some of those spousal impoverishment provisions were in that bill, and when we repealed the law, we still kept that in the law.
It's because he kept the Medicaid side while they gave up the Medicare.
So join me in thanking Congressman Waxman, Diane Rowland for their to stay there, and we're going to bring up the rest of the panel. And Judith, if you want to come up and maybe sit next to Congressman Waxman. Mark Leeds and Judy Pater should come up. They're going to join the conversation, talk a little bit about their unique perspectives. Mark is, come on up, you can cross right in front of me. Go ahead. Mark directs the long-term care in the Maryland Medicaid program. He's done that for many years. He's considered one of the most knowledgeable people in the country at the state level, and personally, I can say, having worked with him and seen him, he takes the complexity of the Medicaid system and really makes it work for many people in Maryland. Maryland has one of the most innovative programs in this area because of Mark. Judy Fader is Professor Fader is the founding dean of the Georgetown School of Public Policy. She is one of the most distinguished academics in general, and then her particular area of focus is this in the area of long-term care. She's worked at the Brookings Institution, the Urban Institute, and was very involved in Capitol Hill considerations as well. So it's a tremendous honor to have all of you here, and maybe, Mark, I'll turn to you first for a few minutes of discussion, and then we'll be able to take some questions and have a conversation with everybody.
Very good, and I think you all have gotten a pretty good background on some of the history of kind of Medicare and Medicaid as it affects long-term services and supports that are needed in the community. As Josh said, I've been involved for a long time with the Maryland Medicaid program, and we've always had what's been referred to as the institutional bias. When Medicaid was developed, there were mandatory services that states had to cover, and there were optional services. Nursing facility services were a mandatory service. Home and community-based services, personal care, and the like were optional services. Maryland, I think, has always had their head in the right place, if not their money in the right place, in terms of trying to support people in the community. We developed in the very early 1980s a personal care program, which was at that time a state plan option. We also paid for medical day care. We started around the same time in order to provide services to support people in the community, so that those institutional services wouldn't be needed, as long as we could keep people healthy and give them the supports that they needed in the community. Even there, though, that institutional bias played out, and we had a nursing home reimbursement system that was designed to cover the cost of nursing home care, that was designed to increase reimbursements as costs went up, and what we paid for. We started out personal care as a stipend program. We were paying $9 a day for a friend or a neighbor or some caregiver to come in and help a frail or elderly person maintain in the community. And by the way, the rule at that time was we could not pay family members for personal care services. And again, when funding was an issue, the funding always went to the institutional services. In Medicaid, unlike Medicare, as was said, Medicaid is jointly administered by the state and the federal government. The state has to come up with the state share for funding any services, and that applies if we want to improve services, improve reimbursement rates, add new services. We have to come up with the state share of that, and then there are federal matching funds available. In Maryland, that's generally 50-50 for most of our basic services. That's kind of a base rate because Maryland is a relatively wealthy state. Other states get higher federal matching amounts based on kind of their individual situations. The home and community-based services waivers that the Congressman referred to really gave Maryland an additional tool to cover people that we would otherwise be paying for. If they were in an institution, they would be covered by Medicaid because of the very high cost of of the institutional services. These are generally people, in many cases, people who were never extremely low income. They weren't on Medicaid or receiving any kind of public assistance when they were in the community or throughout their whole lives. But when faced with the expense of nursing home care, all of a sudden, they spend down to that $2,000. They'd spend, whatever income they had, they would contribute to the cost of their care, and they would become eligible for Medicaid. Having those, what we call home and community-based services waiver programs allowed us to pay for services in the community for at least a segment of that population. They did have to meet the institutional level of care. They had to be medically eligible to be covered in a nursing home. The program had to be cost effective relative to the cost of nursing homes. There was still an income limit. We could cover up to, and this is the case today, up to 300% of the Social Security income limit, which is roughly $2,200 a month. And we can limit slots because unlike an entitlement program, a waiver program, we could limit because there is a cost. I mean, we say that it's cheaper, more cost effective to serve people in the community, but the fact is, when you make these services available, they're available to a lot more people who would be in the community, who might have been receiving services from their family members, who wouldn't have gone into a nursing home. So we're always paying for more people when we cover more home and community-based services. Most recently in Maryland, we've taken advantage of some of the new federal tools, and we've had enhanced federal matching funds available when we move people out of an institution into community-based services. We have what we call a Money Follows the Person program. We have a balancing incentive program where the federal government will pay more for home and community-based services. And then the big program that Maryland has really recently taken advantage of is this Community First Choice program. 6% additional federal matching funds, but really an opportunity to cover many more people and many more services in the community. And now in these programs, family caregivers are allowed. We pay frequently for family caregivers. There are pluses and minuses associated with that. We're paying in some cases for services that would otherwise be provided for free. There are quality of care issues, probably both on the plus and the minus side. Really, the only real prohibition under the Community First Choice program is that we cannot pay for the individual's representative. The person who sits down and develops the plan of service with that participant can't really develop a plan that says, and the plan is for me to be paid to provide that care. So again, that also creates a challenge for us because in many cases there is only one trusted person or maybe a family member that can be working as that person's representative. But we also appreciate the conflict of interest that's associated with that. So again, there are challenges and opportunities associated with that care.
Great. Thank you, Mark. But before Professor Fader takes over, I just wanted to say that we have heard about the scale of the problem from Jennifer, the personal side of it, the history, how states are trying to move forward. So you've got the job here of looking over that expanse of need and history and saying what is, I'm not going to let you just jump right in. I'm going to tell you what we're counting on you to do here. What is the vision for this? How do we get to a point where, people in Judith's situation have a better access? People like Mark can make it work easier at the state level, who are really trying to do that. And we can fulfill what Dan Rowland and Congressman Waxman were saying, was sort of the arc of history from a pure Medicare, hospital-based coverage, all the way out into the community.
Funny you should ask, Josh. So I think, as you can hear what everybody has said, that it's clear that if you're committed to health, well-being, and financial security for people who need long-term supports and services and their families, you've got to believe in a strong federal role for financing those services and for making them available everywhere. And that's because the need for extensive, expensive long-term services and supports it's an unpredictable financial catastrophe. And it doesn't happen to everybody. We hear sometimes that everybody needs long-term care when they get old. That isn't true. And we know that it's not true for younger people with disabilities, whom Jennifer showed us account for about 40% of the population who needs care. And even among people who are turning age 65 today, about half of us are going to die without needing any long-term services and supports, and a small proportion of us are going to end up having to spend hundreds of thousands of dollars. So that's the kind of event, an unpredictable catastrophe, where we rely on insurance, where everybody contributes something so that the people who need it can draw on it when they do. But we don't have that insurance. As Jennifer explained, for a number of reasons, private insurance has never worked in long-term care, like long-term services and support. You can call it either one, just care about it. Medicare doesn't cover those services, as Congressman Waxman said and Jennifer explained. And the hugely valuable Medicaid program, which Mark has described how he's doing the best he can to make it a good one, it provides protection only after financial catastrophe strikes, because you got to give up everything in order to get it. And even when it does, the services are variable and expanded efforts at providing care in the home, but in most states, limited, long waiting lists, very variable available services from state to state. So can we do something about it? Absolutely, we can do something about it. We can have a social insurance system in which all of us contribute to help those of us who need it, like Social Security, like Medicare. It doesn't have to be everything for everybody. Neither of those programs is. But it has to be enough to take some of the burdens off of families who are really bearing the brunt of the burden, and to assure that people who need care get adequate services. So as you've heard from Congressman Waxman, only the feds can do that. And even Mark recognizes he's only got so much capacity to derive dollars from Maryland and in Maryland to take care of that population. And this is a generous state. So you need a federal program to do it. And along lines that we heard from Congressman Waxman, I'll just kind of tick off some of the efforts we've made. It is a real challenge to move this ball forward. I had the privilege of working with Congressman Waxman when I was the staff director of the Pepper Commission, chaired by Senator Jay Rockefeller in the late 80s. And that bipartisan commission, made up primarily of members of Congress, actually supported a social insurance program for home care and initial stays in a nursing home. And in fact, on a commission of 15, 12 members voted for that, only 3 voted against it, and that was a much stronger vote than we got on something sort of like what we've ultimately passed in the Affordable Care Act. That was only an 8-7 vote. And it made it seem like maybe we could really do something about long-term care. It might even be politically easier than getting health insurance for everybody, because there's no entrenched insurance industry in long-term care. Nobody's afraid of losing the plan that they have, because nobody's got a plan. And so it seemed like maybe we could move this forward. But no, the reason I've decided we got a better vote, and I think Congressman Waxman would back me up on this, was because it just wasn't real. What was real and politically live was the issue of expanding health insurance coverage, and that's where people, members of Congress, were much more dug in, and it was harder for us to get a majority. The limits of social or a limited social insurance program for long-term supports and services was also part of President Clinton's health reform proposal. Now, talk about not real. That whole bill was not real, so we didn't get health insurance expansion in that era, much to the chagrin of many of us. But nobody even remembers or knew at the time that that some kind of social insurance for long-term services and supports was also in that bill. And when expansion of insurance protection became possible in Medicare, which ultimately became the Medicare Modernization Act and the expansion of Medicare to cover prescription drugs, long-term care wasn't even discussed as a possibility. Long-term services and support, some kind of limited social insurance, voluntary, was in the Affordable Care Act. That was kind of a miracle. The whole passage of that law was a miracle, but a real miracle was that with Senator Kennedy's support and the perseverance of his staff, showing the importance of champions like Congressman Waxman and Senator Kennedy, that became a part of the original law. But its support was so weak, even among Democrats and certainly with the administration, and its design so flawed. It was a voluntary social insurance program. That's kind of hard to make work. You kind of need to make everybody participate to make it work. That it is a piece of the ACA that Democrats joined Republicans in repealing, and so it is gone. And the commission that was established to think about or propose an alternative that I was a member of a couple of years ago so it came about along with the repeal. It was dominated by the thinking that the whole idea of investing in an expanded social insurance program was too challenging even to talk about. And so the majority of the commission decided they couldn't discuss it, and then 5 of us went off and recommended what it is that we need, which is a public social insurance program. So I'm sad to say that in practice, when you ask me to talk about the federal perspective on long-term supports and services, in practice, the federal perspective is dominated by a concern about the money. Now, I'm not saying that the concern about money is not justified, but families are devoting enormous resources, whether we count them or not, to caring for people at home. And people are getting inadequate care, and sometimes we just have to collectively raise those resources in order to care for each other. So my question is, for all of us, is how are we going to get to a point where that actually is our point of view? And I think that Congressman Waxman gave you important pointers, and he knows way better than I, on the value of what everybody's doing in terms of the research and documenting the problem and calling for action based on demonstrating how the problems that families and individuals are facing. And I want to think about what it is that's going to take us over the top. And my view is that we're going to need a real change in the way people think about long-term care. We're going to, and they need to share that with their elected officials. And that is, this is not a personal or a family responsibility alone. Yes, we all want to and need to take care of our loved ones, but you are right. Your job is to be a loving daughter, not a full-time caregiver or coordinator and coach. And so we owe you the thinking that protects you and enables you to live your life at the same time your mother has quality care and lives hers to the best. So where's that going to come from? Well, I think there are some baby boomers in the room. I was going to say, wait a minute, I'm not sure. Maybe few of us. First of all, we baby boomers are coming. And not only does that mean that this problem, unless we do something, is going to get worse because states just can't keep up with it, and Medicaid is not enough, but it means that we baby boomers know how to get what we want and need. And so we are going to have to get active on this. And we will be joined, I believe, by our children like Judith, who want to give us the best, but also want and deserve their own lives. And we will be further joined by younger people with disabilities who see the access to services that will enable them to be part of the community and to live productive, quality lives, that is a civil right. And they will be joined by the workers who are increasingly demanding that having decent pay in a decent job is a worker's right. And together, Henry, I'm about to make a demand that you go back to Congress for 40 more years. It may take us that long, but we'll be with you, because what we will need is a champion, more than one, but I'd settle for one more champion, like Congressman Henry Waxman, who will lead the way forward. Thanks.
Well, thank you. Thank you for that. Thanks you to all of our panelists. And I'd like to ask one question, and then I will turn it over to the audience to ask questions. So we are moving into an election year, and aside from bringing former Congressman Waxman back to Congress,
what else are we going to do?
What do you anticipate, or what could we do to move long-term services and supports into the agenda in the coming year?
It takes a president to have a priority for long-term care to get it done. I think it's very hard to mobilize support from just the Congress, so I think we need to put it on the agenda of the presidential candidates and elect the right president.
May I respond to that?
Yes, please do.
President Obama wanted to fill in the ability for every American to buy health insurance. And the biggest problem with just getting health insurance coverage is if you weren't on Medicare and you weren't on Medicaid and you didn't have insurance through your job, you had to go buy an individual policy. So he focused on the idea of the individual policies being available, and that was a struggle. And of course, that required a mandate because you have to spread the risks. But I think people would look at long-term care and all the parts of it in the continuum of the care as clearly an insurable matter. We buy home insurance. We buy home insurance in case lightning strikes or in case something terrible happens. Or we buy accident insurance for your driving in case these terrible things happen. They don't happen predictably, but when they do, they should be paid for, and everybody's contribution to the insurance program pays for it. The fear with acute care insurance is that, well, maybe it's going to cost more, but you can get a pretty clear estimate if you said that we're going to cover nursing homes, we're going to cover community and health-based services, and if you said to everybody, you're going to contribute a small amount of money, because it would be fairly small, into a program, and you would have peace of mind and everybody's in it, I think American people would understand it. I think we do need a president to make this a priority. Now that we've put the Affordable Care Act in place and we've done some of the other things that we've been trying so hard, pharmaceutical coverage is in the Medicare program. That was a huge issue. This is the next huge issue, and I hope that we can have a president who would put an emphasis on this, and if she pushed for it, I think we can get it done.
Great, thank you. Any questions from the audience?
Hi. I definitely agree with what you were saying about needing this healthcare. We need everyone to pay into it. Obviously, I did a lot of flying, and the insurance for a plane costs even more than a plane does. So, for your statement, I definitely agree. But I was going to ask, how feasible do you think this would be? Because I've worked with people who can't even afford the Affordable Health Care a statistic that came out in the paper a while back. I can show that too, but I just wanted your opinions on that.
Well, the last thing you said, when you say that a small percent of people count for the bulk of costs, that really is what insurance is about. So and sometimes people say, well, why should I get insurance? I'm not going to get anything out of it. I'm going to pay more than premiums than I'm going to get in benefits. And what you should really say is, thank goodness, because I didn't get sick enough to need benefits, or I didn't have the accident, or whatever it is. So I'm encouraged by Congressman Waxman saying that people will get this, that if they pay something, that we can all protect each other. But I've been at this a long time, right? And so I think it took us all this time to get the Affordable Care Act, which isn't affordable for everybody. That's true, and it's because we didn't get enough resources into it. So I think it is going to take time to build this. It's going to take time. It's going to take a change in attitudes on other programs. We see, I don't think, enough a defense of the entitlement programs that exist. The recognition that Medicare needs to remain a strong program with publicly run, that Medicaid cannot be turned into block grants and just hope for the best, that we need a strong federal government. And I think that we need to start demanding it and exploring it and building the groundwork and then elect people who are going to deliver for us.
Thank you. Yes?
So one of the subtexts from most of what you're saying is that basically unless Democrats control Congress and the White House, it's going to be really hard for there to be expanded long-term care.
No, it's even worse than that. It's unless progressive Democrats control the Congress and the White House, it's going to be.
So, but on another note, you know, when Sarah Palin was nominated, she talked about the one thing funding she liked was disability funding. If anyone watched the Colbert Report the other night,
it's true.
Jeb Bush talked about disability funding, and
Good.
what Trump is doing to the Republican Party is he's basically realizing this entire party are people who receive Medicare, don't want Social Security cut. So I'm wondering, in case there isn't, is there space and is there already political organizing done around the idea of providing this long-term care and disability as kind of a separate stream that falls within the kind of disability funding ambit? And because Democrats aren't going to control things forever, and there has to be some kind of space to work with other things so stuff doesn't get cut. I mean, you saw that with the Bush administration. They eviscerated science across the board, but they expanded Medicare, Part D, and they did this stuff with AIDS. So I'm wondering, where is there space right now for maybe some of the positive feelings about disability funding to be geared into kind of doing this kind of stuff?
Clearly, the disability community, when it chooses to be involved, is a very powerful force. And one of the reasons many of these Medicaid provisions went through was in the midst of the AIDS epidemic. The disability advocates there really pushed for hospice care, home and community-based services, and other things. But, you know, the issue is always financing, and we haven't Congress today that doesn't want to spend money on any of these things, even if it is disability.
I would jump into that question, which I think is a good one, to say that one of the things that Mark has worked on in Maryland is the self-direction component. And I think that the idea that you could pick someone when you're aging to help you live at home, that you could pick the Kevin, I think, that Judith talked about, that, you know, is not a political idea. And I actually think that trend and that foresight in the Affordable Care Act to give that option may help broaden the political constituency for this, as people realize that maybe that's too much of a hope. But I can say, as we were explaining what we were doing in Maryland when I was working with Mark, that was not something that broke down along political lines.
Yeah, and go ahead, Mark.
No, and I think that's one of the values that kind of appears in many aspects of the Affordable Care Act is consumer empowerment, self-direction. That these provisions really are valued throughout the various aspects of the programs.
Yeah.
I want to just jump in there. I would challenge the assertion that this is a partisan matter, or you need to be a super liberal Democrat to want to do something about it. These problems are suffered by Republican as well as Democratic families. The dilemma is this: if you ask people to pay a small amount of money and have peace of mind, it doesn't have to be very expensive, but it has to be mandatory. Now you have a lot of people say, I don't want to buy it. We saw the hue and cry over the requirement that there's a mandate everybody get health insurance. That, by the way, came from the American Enterprise Institute, a very conservative group that said you cannot get an insurance system to work unless you could spread out the cost to everybody, which means you've got to get everybody in there. So we've got to start thinking about human nature. In our pension plans, if you ask people to opt into the employment pension plan, they usually say, no, I don't have the money for it. I don't want to spend that money on that. I've got things I'm doing. I'm just starting off in life, or I've got a family and I want to put the money into that. And then before you know it, they need it and they don't have it. So one of the human nature evaluations is enroll them in it, but give them the option to withdraw, or something where people don't feel like they've been forced into something. They'll later be grateful that they were in it. We've got to start thinking along those lines. Now, one of the approaches has been, well, why don't we have private insurance cover this? And I happen to be on another committee, even chaired another committee called the Oversight Government Reform Committee. We got a lot of oversight work that got attention, but we had legislative authority over some things that especially when it applied to government employees. And we asked the Office of Personnel Management to go out and find and evaluate private long-term care insurance plans. No one would have to buy it, but it would be made available to government employees, solely paid for by them, no government expenditures. And this was an approach to take a private insurance option and get a lot of people to participate in it. Well, we saw that pie chart, very small private insurance coverage. A lot of people have not chosen to go that route. It's complicated. They think I'll buy a plan. They say, well, I'm not going to be more than $50,000. But 20 years later, when they need nursing home care, that inflation has eaten up that amount. So we can look at private options. We can look at public options, but this is an insurable option, and we need the sense that we all have to pay into it. How we get there is tough. Maybe we need a Republican who will take the leadership on this to say, this is a problem and it's got to be resolved. And it's not, when insurance was not available, because people couldn't buy it anywhere if they lived in areas where there are a lot of fires, the government stepped in and said, we'll make insurance available. Where insurance wasn't available for certain automobile drivers, government sometimes steps in and says, we'll make this insurance available. But this can't just be voluntary alone if we're going to spread the costs out. If we don't spread the costs out, all the insurance problems end up to be the same. You get a narrower group and the costs go up and it's unaffordable.
Great. Thank you. And Judith, is there something you want to add?
I just wanted to echo that the idea of needing to pay attention to human nature. My mom like went to the dentist twice a year and flossed. Like she took care of herself, and she had on her to-do list to get long-term care insurance, but it didn't happen before she needed it. So some sort of, that's the kind of thing we don't want to happen.
Great. Well, please join me in thanking Professor Wolf and our great panel for